Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
But anyway, welcome to dental webinar series today. Today we are privileged to have two dentists, teachers, professors, leaders in the field who are willing to, who have given their time to speak to us today on various topics. The first is Dr. Don Curtis. Dr. Don Curtis is a professor at the Division of Prosthodontics at the University of California in San Francisco. His research interests include evaluating bone strain around implants during wound healing and how bone implant contacts is influenced by strain. Dr. Curtis has had over 80 publications in peer-reviewed journals, including head and neck, bone, medical education, and numerous basic science, medical, and prosthodontic journals. Recent publications have focused on maintenance issues related to dental implants. Dr. Curtis is also involved in professional development and how students accept feedback. He's also involved in nationally organized dentistry as an authority on clinical decision-making in the use of dental implants and speaks on clinical topics nationally and internationally. He's past president of the Pacific Coast Society for Prosthodontics. The American Board of Prosthodontics is also a fellow in the American College of Prosthodontics, a member of the Omicron Kappa Upsilon, the National Dental Honor Society. Doctor, it's a privilege to have you on Dental Webinar Series today. Please take it away.
Well, thanks for the nice introduction. Thank you again for the nice introduction. It's an honor to be doing this. I heard about this seminar series and I was initially impressed, and this morning hearing more about it has made me even more impressed. I think, as we were talking earlier, this is one of the good things that's happened in response to the COVID epidemic, that it's brought people around the world in academics closer together, and there's a more thorough exchange and a better understanding, and I treasure that. As I mentioned earlier, 2 of my 3 kids have done Peace Corps experiences, and both of those were in Africa and Benin in Niger, and so I'm really glad to see outreach projects like this where educational information is dispersed, and I hope to do a little of that in the next hour this morning. The topic I'd like to talk about is risk assessment, how we use risk assessment in implant dentistry, and how that information in your risk assessment can be used to provide a more thorough exchange with the student, with the patient in consent and in treatment planning, and how it can influence maintenance. And I'll do this from the perspective of having been full-time at the university for many years, but also somebody who's grounded in private practice. So I use some of the things I describe in my private practice, and I think it's helped me do a better job for my patients and be more effective in outlining treatment options and in the relationship building with my patients. So that's the topic today. It's about how we decide on certain issues, how we assess the patient for the amount of risk that they have, and then treatment plan forward. So the first question that comes to mind is, why risk assessment in dental implant treatment? You've heard about risk assessment in assessing patients for caries, called CAMBRA, that was developed by a colleague that I've actually written with John Featherstone. And why are we initiating something somewhat parallel to that in the area of dental implants? It's just because I think we tend to see implants and teeth as equivalent, and they're certainly not. That a lot of the characteristics with implants that can create problems and misunderstandings are very, very real. And that compared to teeth, implants fail more rapidly. There's fewer symptoms when failing. So patients need to be more aware of what to look for, and we need to be more astute to look at things. The diagnostic criteria is less reliable. For example, and we'll talk about this more, bleeding non-probing around teeth means quite a bit. It really gives you accurate information about levels of inflammation, but there's about 20% more false positives with bleeding non-probing around dental implants. So diagnostic criteria are less helpful. Patients, as we'll talk later, are much less informed about failure mechanisms, or that implants in themselves can actually fail. Patients have heard about caries. Patients have heard about periodontal disease, but when they do surveys and they ask patients that have implants, are you aware that these implants can fail? About 74% feel that they had implants placed thinking that they were lifelong lasting and that there was no problems that they needed to be worried about. So it seems also that medications seem to have a more significant impact around on the bone around implants than in impacting natural dentition. Some of these and some of the risk assessment tools that we've developed. When people always ask, when did you become interested in this? Well, I, like everybody else, I have been using implants and having some success with implants for a long time. But I started noticing maybe 15 years ago that too many of the patients I was treating were starting to get marginal bone loss. There'd be suppuration. There would be radiographic evidence of bone loss. Nothing too alarming, but it was an issue, and it wasn't really addressed in the literature as to why we were seeing this bone loss, and it just wasn't clear to me. I wasn't sure what to tell the patient. They had invested time and treasure, and it was always a difficult conversation of saying, you've got some bone loss. I think we're fine for 5-7 more years, but it could be a problem. And it seemed like there was extreme variability. This is an example where, the general rules that we learned in dental school about emergence profile, about tissue coverage, I'd always been breaking in with dental implants. This is a patient who had an implant in the position of number 6, with 6 moved into the position of number 7. Patient didn't like the crown, came into our office like this. I placed a provisional as shown to the right, worked back the tissue, did this tissue displacement, something we obviously would never ever do on a natural tooth, right? But we do it. And then on 10, we did a bulky Emax crown to try and match the canine that was in number 7. And then worked on getting the height and the displacement of the tissue. But the point is, we got an aesthetic result and the patient was happy, but we did things we would never do with conventional prosthodontics. And I've noticed in my practice where I did see some patients, some people were very resistant to breakdowns. Some people would get Peri-Implantitis and other people. On the other hand, I would see patients, like this is a patient I treated maybe 13 or 14 years ago. Patient lost an implant in, number 21. And we did some bone grafting and soft tissue grafting, stabilized things. I completed a fixed prosthesis with a cantilever as shown on the lower right. Patient was okay for 4 or 5 more years, and in the video here, you can see what the impact is.
I've had 5 implants for about 10 years. One of them has failed. The others are not doing very well. I have good oral hygiene. I have no plaque, no periodontal disease. And I am so sick and tired of these implants. They just cause me to worry all the time. And my mouth is sore and my mouth is bleeding.
So I showed these videos. I have 44 videos. I'm obviously not going to show them all. This is the only one I'll show, but of patients that have failing implants from my practice. And part of that is because I've done an awful lot of implants. But it is such a difficult time for patients when they lose an implant. They have such high expectations, and the social media messaging is such that they don't expect anything to ever go wrong with their dental implants. And so when it does, it's devastating. So the take-home message from this is some people, I get away with all sorts of tissue coverage and nothing happens, and other patients are very vulnerable. So when you are working with patients, I think it's very good to try and stratify where the patient is on that continuum. Are they very resistant, like that young patient I showed with the canine? Are they very susceptible, like the most recent patient I just showed? When you identify those patients, you can set up, a more thorough consent, outline patient responsibilities. You can put them on more stringent recalls. There's a number of different interventions. You can make sure there's more attached keratinized tissue around the implants themselves. There's a more robust seal as a result. So what I did was work starting about 6 years ago, started working with a group of people to try and identify what those risks were so we could look at aggregate risks, so we could try and identify where people were in an aggregate risk score on that continuum of very little to quite a bit of risk. And we looked for risk factors in history, risk factors during the clinical exam, and risk factors based on what we do. That's the flow. Patients come into our office, we do the history, then the clinical exam, and then we, make choices and decisions. So that's what we did. And this led to maybe 12 publications so far in JADA and International Journal of Prosthodontics, in the ACP journal and the Journal Perio, and a number of others. And what we've doing today is just outlining some of the findings from some of those articles and some of the ongoing projects. It's really a large group. There's about 25 of us, so I'm speaking for them. I'll speak about some of the results of some of the most recent publications. Ivy Zelmers was really interesting because she did her master's with me at UCSF, and she did a survey of dental hygienists in the United States, 10,000, to ask what their knowledge, attitudes, and beliefs were with regards to dental implants. And what was very interesting is about 33% of the hygienists in the United States do not believe you should ever probe a dental implant. And that's despite AAP and the European Academy of Perio both suggesting that the delta in the pocket depths around dental implants provides diagnostic information that's important. So we'll talk about some of these papers and projects. I've been doing this long enough that actually one of the dental students I had many years ago is now my boss, which is great, Dr. Yvonne Capilla. And so let me give you an example of how this works. We identified 20 factors that can contribute to peri-implantitis risk. And we gave a weighting to each of those factors. And so you have a questionnaire is being shown here. And a patient comes in and you go through this checklist. And if the patient's not a smoker, they get a 0. If they have a measure of poor glycemic control, and there's subscales for a number of these. For example, in diabetes, if the patient is between 6 and 7, it's some. If it's above 8, it's even more points. Same with periodontal disease, as we'll talk about. So HbA1c, if it's between 6 and 7, it's 3 points. If it was higher than 8, it would be 6 points. Periodontal disease is active or inactive. If it's severe or moderate, you get a different point allocation. The use of different, in the US, SSRIs, selective serotonin reuptake inhibitors, it's 1 in 10 patients are being treated, 1 in 10 people in the United States at some point in their life are being treated for depression. So it's a very common medication that you see. And then whether it's placed into the maxillary posterior where it's higher risk. So for this particular patient that came in, we used this checklist of 20 different risk factors. The patient had a total score of 8. So they're at medium risk, and we see where they are on this risk assessment questionnaire. The obvious question is what is the sensitivity and specificity of this test? And we've actually studied that and have 2 studies that are actually, one is submitted, and basically the positive and negative predictive value is actually pretty good. I mean, if you have a patient that comes in and has very few risks and a point score of less than 6, there's a very, very high chance that patient will never, ever have significant bone loss. Conversely, if they have higher risk, it's a much higher chance that they, in fact, will have risk. So the scale is not perfect. The model is predictive, though, and is street ready. So we're using it in a number of clinics. The VA has used it, and we're studying it. So what you can do is, in this specific patient that had some measure of poor glycemic control, and the points allocated appropriately here because the periodontal and the SSRIs, you can look at clinical management considerations. And you can see here we've highlighted the best information from the literature in one of the publications that's available. It's the iGEOMI article in 2019. And all the relevant information about each of these risks into a little table that's just clinical management consideration. The patient has diabetes, but if it's clearly controlled, similar survival rates. At the time of surgery, the HbA1c is very critical, more frequent recalls. If there's periodontal disease, stability achieved prior to implant placement is critical. If there's use of SSRI, about 20% of people that are taking an antidepressant, the medication will induce bruxism. So being aware of that and considering the use of a night guard, for example. So let me show you another example of how this questionnaire might be used, this risk assessment questionnaire. So this patient came into my office, had an existing implant, and wanted me to restore it. I'd had a friend who had come in and I'd restored their implant. And so he had a lot of bone loss around his existing teeth. So he had periodontal disease. He was taking an SSRI. We did the point scale in a total. It was 8. So he was moderate risk. But the literature and the guidance from this scale was that if a patient's willing to be on more regular recall, but does have a history of periodontal disease, they in fact can be maintained. But it also shows people with periodontal disease that aren't active in their recall patterns fall apart much more quickly. Also, the more recent literature shows that there's maybe 6 different SSRIs out there. If it's sertraline, which is one of the types, it's much more problematic for bone loss around dental implants than some of the others. So a rigid maintenance program. So here's an abbreviated checklist that we use in the dental school. It just goes through the patient history, the clinical findings, the planning, clinical decisions. This is a patient, I've treated many patients like this. It was using a framework and denture teeth to save money for a patient and screwing it down. But if you have a patient that has some diabetes and some periodontal disease and isn't willing to really do a great job of accessing the tissues, and you have so much tissue coverage, those implants are going to head south and in a hurry. So I think another reason a risk assessment questionnaire and a systematic approach, kind of a outside validation of your clinical judgment and intuition, so to speak, is to use this checklist. Even if you think, oh, I know these risk factors and I can, empirically just come up with the risk and talk about this to the patient. We've done some studies. Dr. Ben Susan is one of the residents that is worked on this, is we're not consistent in our appraisal. So if I ask you as an audience, what do you see in terms of risks for this patient? Clinical exam, basic look. You're going to look around. You're going to see a few things. What do you see? What are the risks? And how will your colleagues evaluate the same patient? Are they going to see the same risks? They're going to see different risks. It's just astounding to us when we do these scenarios and present this to different groups, the variety of responses. This is a patient who had a fixed prosthesis from number 8 through number 10. And there was external root resorption on number 10 and was going to need an implant or implants in the number 9 and 10 area. So this patient, for sure, you see the plaque levels. You see very little attached tissue when you have very little keratinized tissue. In a site that's a higher risk for implant problems because it becomes more sensitive. You get less compliance of patients in brushing. It's just much more tender for the patient. You see a thin tissue phenotype. This has also been shown to be a risk factor. And because it's a risk factor, there's much more recession or pulling back of the tissue than in a patient who's a thicker tissue phenotype. The patient also had some glycemic control problems, as many, many Americans do. So how do you communicate that, prognostic uncertainty? The constant in biology is variation. Everybody responds differently. But getting a sense for the aggregate risk a patient presents with, we think is important. So how do you communicate that to the patient? So that's what this is all about. I think it's also important to show that patients are very not only misinformed, but uninformed. As I mentioned briefly earlier, about 74% of patients who have dental implants, and this is in a university setting, do not know anything about Peri-Implantitis. About 70% believe their implants are going to last forever. And consent forms don't work. I think all of us have been to see a doctor where we're asked to sign a consent form. I sure don't read the stuff. Patients tend to default to your expertise and knowledge, and they don't critically review things. They defer to, we all defer to the expertise that we're seeking. In the social media messages patients see are oftentimes misleading. If you Google dental implant replacement, it's emphasizing certain things that really paint one half of the picture, but they exude permanence and confidence and smile and sorts of things. And many dental implant centers, some national dental implant centers, state that you're starting a journey to give yourself a healthier smile that will last a lifetime. Well, implants can last a lifetime in some cohorts with a certain level of compliance, but this certainly isn't true for everybody. And they tout on a lot of these websites, the success rate is, again, over 95%, which, again, it can be true, but it depends on if you're looking at survival or success. And if you're looking at Peri Implantitis, the studies also show by implant about 12% and by patient about 20% of Peri Implantitis or marginal bone loss over a 7-year period. And those are from Rakik and Lee and these big systematic reviews where they're evaluating all the best literature, each with 45 or 50 articles in each of those two systematic reviews with meta-analysis. So Peri-implantitis is occurring much more often than oftentimes clinicians believe or patients believe. So I think the things that I see on social media that are most upsetting is that they're oftentimes taking a partially edentulous patient and suggesting that if they're even just missing a few patients, that it may be preferable to perform an all-on-4 procedure. And that's certainly, in my opinion, irresponsible and just a money grab. I spoke earlier about surveys of dental hygienists never ever probing and how you miss things. You miss things when there's a buccal plate that doesn't have bone and it's an isolated pocket there. And, a corrective procedure, even getting some more attached tissue there could affect benefit for the patient, even if you don't graft. And failure can happen really, really quickly. And it's just, we won't go into examples, but I think we've all seen it. I've certainly seen it. The one I'm showing here was a physician who had recently retired, came in, initially took out all his molars, kept him in bicuspid, shortened dental arch. He did fine. He then started getting mobility and discomfort in the lower anteriors. We placed implants. He was recalls, and he was doing great. And then he just decided he didn't want to come in for a couple of years, and things fell apart so fast. Within 3 years, he went from normal bone levels to what you see here on the right. So, and that's what's borne out in the literature is failure, especially in people that have the tendency towards periodontal disease. Things can fail very rapidly. I think we all have optimistic projections for our future. If I were to tell you that statistically speaking, 23% of us will die of cancer, and then ask each of you to tell me what your risk of cancer individually, studies show that over 95% of you will pick a number well below 23%. It's called optimism bias, and it's a survival mechanism. It's kind of our shield to face the day where we look optimistically, and it serves us well. It makes us more persistent, confident, and successful in many ways, but it's also not totally realistic. When you combine the natural human tendency to be optimistic, both from the clinician and the patient, you get a confluence of incorrect choices. And I think we are better grounded by having a risk assessment questionnaire to give us a truer picture of what the risks are and what the responsibilities are. This is a rehabilitation that was done, and I never would have thought that this would chip in the first week after delivery, but sure enough did. And on the upper is caries, recurrent caries around one of my crowns. I just wouldn't think. I would think my crowns would fit so well that that wouldn't happen. Or this implant-supported hybrid upper and lower. The statistics are that about 33% at 5 years will have some mechanical and or biologic complications. I don't really say that to patients because I think I'm better than that. But the reality is everything regresses towards the mean, and we may not be as good as we think we are, and we hold those perspectives because of Optimism Bias, a great book by Tali Sharot, if you ever want to read it. So risk assessment using a questionnaire and then sending this information home with a patient is not about trying to avoid all risks, but making sensible, considered, and ultimately defensible decisions. So this is a lecture about looking at managing implant patients from a way above level, just an overall perspective. It is not the granular procedure type lecture. So I think I mentioned that the major systematic reviews and meta-analysis on Peri Implantitis, the prevalence, it should ground us because it is really pretty high by implant and by patient. And what I've done here is I went through each of the articles, and this is Lee's systematic review, the 45 articles, and I just circled the ones that were 10 years or more. And of those that are 10 years or more, it's even high. 10 years follow-up or more. So where does this topic of risk assessment come from, and how was it used? Risk assessment is actually a significant part of it was one of 4 tenets of the Affordable Care Act that was advanced in 2009, and hopefully now under Biden will be advanced. And if you go to the Centers for Disease Control and Prevention, there's lots of articles about risk assessment, and it explains it in much more detail. But the idea was that you can, like falls, elderly people falling, Medicare spent over $50 billion in 2015. There's a risk assessment questionnaire to determine how ambulatory, how mobile a person can be based on certain minor tests. That one is called the chair test. And there's another number of others. There are questionnaires that you put a patient through to determine what their risk of a fall is. And because the financial consequences and the mortality and morbidity are so significant, those risk assessment questionnaires are used in medicine. There's probably 700, maybe 1,000 different risk assessment questionnaires. The most famous one we'll talk about in a minute. It's what is a person's propensity for a stroke or a heart attack. But there's also ones for diabetes. You look at all the parameters of weight, etc., and family history, sunburn, depression. There's lots of risk assessment questionnaires in medicine. We haven't used a lot in dentistry. The most famous one comes from the Framingham study that started after World War II, where they have now 4 generations of patients. And it's the risk for what is an individual's risk for having a heart attack or stroke in the next 10 years. They look at risk predictors and modifiers. The more data you put in, the tighter the confidence intervals. And they basically come out and say whether your risk is low, medium, or high, and then they could outline what your risk would be if you did certain interventions. So it really gives the patient a realistic perspective on what their risk is and what they might do to decrease their risk. And when I took this, when I turned 55, I could see from the tables that if I exercised more regularly and controlled my blood pressure, that I could decrease my risk by 2%, which I did. So I think it really incentivizes compliance. And that's what I've found with this risk assessment. So as I mentioned, we came up and published on what we found and provided some validation from 2 studies on what the risk factors are in history, in the clinical exam, and in the clinical decisions and the findings that we have, whether we cement restorations, whether we create a restoration that limits access, whether the position is appropriate with 2 millimeters of buccal bone, et cetera, et cetera. So I'm just going to give 3 examples of how using this risk assessment questionnaire, which is available. I'll give you a couple websites. One is mydentalrisk.com. We have the whole questionnaire there, and sometimes I'll send that link to a patient and ask them to take the test before they come in for their consultation appointment. We've got a new website that has all the free downloadable forms that I hope to get out in the next month, and I'll be sure to let people know about that. And everything's free, of course. I think by using this risk assessment questionnaire, I've lost very few patients. One of the questions that's asked most when I lecture about this is, how many patients do you lose by telling them what their risks are? And sometimes I do lose some, but sometimes those patients actually come back 6 months later saying, I think I'm ready now, and I appreciate your candor in telling me. But I think it's also one of the things we can do as dentists to use this as leverage to help them motivate themselves towards a better general health. Diabetes, let's look at an example. So smoking, it's dose related. Sanchez and a few other studies have shown that it is very, it's an early effect. It's dose related, impacts the maxilla, surgical complications double. Smoking is a real risk. When we go over that with patients and they see that it's dose related, they oftentimes will become more compliant and try and decrease smoking. So they go sometimes from 6 because they're smoking 20 cigarettes a day down to a 3. And we see that as a success, even if they haven't completely stopped smoking. And diabetes, it's the same thing. We went over this a little bit before, but you don't want to do immediate loading if somebody has poor glycemic control. You need a little more time for osseointegration. You don't want to do surgery if it's over HbA1c of 8. Females seem to be more adversely impacted by poor glycemic control in implants than males. But if you've got a patient who's motivated, oftentimes you can improve their general health by taking them from a 3 down to good glycemic control. Maybe they'll lose some weight. Maybe they'll be more compliant with their meds or some combination. And I think it's a exciting opportunity when we get to have that impact on a patient's general well-being. And that was very nicely written up in a letter to the editor with Dr. Steve Sadowski, who I might mention, I think has the best dental implant book out there if you're interested in a textbook. I think the second way this has changed my practice is tissue coverage and restoration contours. I used to go around the country talking about these massive zirconia restorations, and even talking about how you could contour the zirconia and still only do 4 implants and fewer mechanical complications than hybrid prostheses, but you'd have to bulk it out. And here's some clinical examples. And the outcome that I and many others, I think, used was aesthetics and patient satisfaction rather than long-term biologic consequences. And a lot of these came back to haunt me. Basically, we talked about at the very beginning, the implants are a more fragile system. And yet for many of us, for a long time, we took greater liberties. We displaced more tissue. We did more. And I'm going to skip over this one slide, but this is an example of a patient I did. I'm going to skip the video part, and I want to get to this. Do implant contours matter? You know, the tricky area is especially in the lower posterior. You're starting from a narrower base. The action with the bolus in the tongue and the cheek is here. Getting food trapped lateral is an issue. A lot of times you need to evaluate that in provisionals. Some clinical examples in the lower left. In the maxilla, it's easier to have open embrasures and flat emergence profiles, and you tend not to have problems as long as you have good proximal contacts. But the example on the your upper left, is something that I did as well. But there's more and more data showing you shouldn't do that. If you need to close those kind of embrasures, try and use a tissue level implant. So Daubert, and Diane Daubert has been with a group of us publishing a number of these papers. So we were all taught that things should have fluting and flat emergence profile, and furcations should be followed, and this and that. But when I look at things that I deliver, the implant restorations don't follow any of those criteria. And there's times we can get away with that and times we can't. But we have to do the risk assessment to find out where the patient's aggregate risks are for developing peri-implantitis. And once we know that, we have a better sense of whether we can get away with some of these things that we consider doing. So risk stratification. Another thing that I like to do oftentimes is not use fixed. A number of reasons for that, but use the plunger cusps, either the Swiss lock or MK attachments, where you use a bar and then a plunger cusp that goes in the lateral or from the medial, and you make it fixed. You have the advantage of the flange, you have the advantage of being taking it off and accessing and cleansing more readily. And in a patient who is edentulous, really wants something that feels fixed, it isn't, one, you have to have enough interocclusal space, and two, you have to be kind of medium or lower force. Somebody high force, I don't like any kind of acrylic resin. I like monolithic zirconia when I can, and I really like some of the newer systems using the 3Y, 5Y zirconia, so that you have the strength of the 3Y and the aesthetics of the 5Y. Plaque levels. This risk assessment questionnaire can really bring people to examine where they're at. I'd like to show you one clinical example. A patient who comes in who's lost a whole bunch of their teeth and wants implants in the upper and the lower and fixed prostheses and can afford it. I go through the risk assessment questionnaire. I ask them to go home and think about it for a week. They've got all the information with them, knowing what the risks are, what the responsibilities include, and they come back and I think this is the slide.
Here,
Yeah.
the right side have big space, so easy to use the frosting and easy to clean. Here side is space is tight, so it's harder to clean.
Okay, so what we're going to do is on this PMMA, we're going to open it up a little bit more and have you wear it another 2 weeks until you can comfortably clean both sides. Then we'll transfer this to the zirconia final prosthesis.
Okay.
I'm sorry. This is a little bit different example. This is a patient that is all implant supported with a provisional, a PMMA provision. We always make 2 PMMA provisionals, one to shape and contour, and we have them back at 2-week intervals until we can take it off and not see any plaque on the undersurface of the prosthesis. And once we can do that, then we move forward with the zirconia restoration. So if it looks like this, then they're not ready for their definitive restoration. So this is what we do. So here's the video I thought was there. This is the one where it puts more responsibility on the patient and where I had the patient review all the risk factors.
So historically, I have not been very good at dental care, which is sort of why I'm in the position I'm in now, at least partially. And my question for you is, how much care would implants demand? And
Yeah, so this is the one I wanted to show you. It's a video of a patient having gone through the risk assessment protocol, going home, coming back, saying he's ready, he could afford it, and him being a little bit contrite and reflective and realizing that he needs to do a better job. When a patient articulates that you want to see, that's a really valuable thing. You know, 70% of the beds in American hospitals are filled with people with preventable chronic diseases. You know, what we do in dentistry succeeds if we're able to motivate a patient. I really think risk assessment is a good way, along with motivational interviewing and a few other techniques, in motivating patients to keep them able to maintain what they've got. So I'm going to finish things up here. We've talked about risk assessment, why it's important, how it clears up misconceptions, misunderstandings of patients, how it grounds the clinician, and how using this in a systematic way, I think, will actually increase the patient volume in your clinic and improve the outcomes for your patients. We've talked about a few of the many factors involved in the process, but certainly not all of them. And due to time constraints, maybe I'll just talk about one real quick study. This is one where we have submitted. It's being reviewed right now. We looked at patients that have minimal bone loss retrospectively and patients that have pathologic bone loss. These are groups, and we looked at 61 patients, and we looked at their risk assessment numbers. So in the patients that had pathologic bone loss, what percentage of them smoked, what percent had periodontal disease, et cetera, and basically showed that our model was pretty good. And the numbers of sensitivity and specificity and positive and negative predictive value bore that out. The validation models of the risk assessment, the area under the curve, and all the other tests look pretty good as well. So it will hopefully be better. It's pretty good right now. And our hope is that it will be even better in the future. There's some modifications we're trying to make to the questionnaire and test in a group of VA patients now. So the last thing I wanted to talk about was why dental implants fail, because I think, we were all brought up on the idea that it's either biofilm mediated or excessive force. You cross over, you get failure. I think it's a lot more complex than that. There's many roads to Rome, and we haven't had a chance to talk about degradation, but it's really a big area, and there's much more information about how bruxing, stress shielding, corrosion, foreign body reaction all comes into play. There's bone mediators. We talked a little bit about polypharma, Diane Dalbert stuff. There's gradients, and there's failure that way. What I've tried to emphasize in this 1 hour presentation is clinical decisions. If you don't have attached tissue, but the patient's at higher risk, probably graft. You do cement it in some gingival, that's a problem. If you place implants too close to each other or to a tooth, that can be a problem, especially if you don't use a horizontal offset. And the big thing is limiting access. If you limit the access and the patient has risks, as some of the examples we showed, you're going to get bone loss. So I have the take-home message that clinical decisions, the decisions we make, are much more impactful than people realize. The people to thank are those, and the take-home message is, I think we rely on our intuition and clinical judgment. We should be thinking bigger and willing to use processes. Processes are used in medicine much more than in dentistry. It seems as if there's almost an arrogance in dentistry that we think it's simple enough or we're smart enough that we don't need what are called diagnostic aids. I think that's a problem. And risk assessment isn't going to chase patients off. It's going to help you build your practice. I think it leads to more informed and collaborative decisions. And both patients and clinicians have unrealistic expectations of success, and that needs to be tempered and grounded. So those are the issues of risk assessment, and thank you all for listening in. Do go to the website mydentalrisk.com, and on that website soon, within the next 6 weeks, there'll be an announcement as to the new website that'll have all the downloadable forms. I mean, you can do yourself right now from the publications, but we want to make it easy for people to use these checklists chairside. I think you'll hopefully find them helpful. So thanks very much, and thanks again for the nice invitation.
Thank you so much, Dr. Curtis. This is, I think, this should be the first lecture that we have on implants, because I realize that this should come before anything else, because we are here trying to place implants without carefully looking to see whether it has margin of success based on the risk of the patient. I have a question here. So I have a patient right now whom the implant has already been placed, but he seems to have a heavy canine guidance. And the implant is on number 11 and heavy. So what are the? I mean, this is already done. I guess This is like after the.
Well, canines are always tricky, and they're always tricky because you've got the natural tooth in 6, and that probably is long enough, and there's probably canine disclusion. You want ideally shared disclusion on 11. So it'd pick up the buccal cusp at 12 or number 10 a little bit. So it's going to be shorter. So there's an asymmetry in aesthetics as a potential complication. That's number 1. Number 2, if you recommend a night guard, let's just say the patient has a reason because there's a real heavy force and a lot of facets. The compliance, there's some recent studies on night guards that show compliance with night guards is only 50%. So how do you know? So the question comes down to, the third part to that great question is, are those high forces going to cause the bone loss around that implant? And you know, that is a great question. I think it's really complicated. I don't think there's a simple answer. I do see mechanisms for it, because there's some animal model studies fairly recently that show proton pump inhibitors that people take for their gut, like omeprazole, which is an $8 billion a year industry for H. pylori or gastric reflux or GERD. Okay, that when they put those into mice for a period of like 3 months, and then they put in implants, and then they have those mice that they didn't give the omeprazole to, and then they look at bone implant contact. The bone implant contact is about half in the omeprazole mice that it is in the control mice. So let's just say this canine implant, if that patient was taking a proton pump inhibitor, it's very likely the bone implant contact is much less on that implant than if the patient wasn't taking it. The equivalent problem doesn't occur on a natural tooth. So medications do seem to have more impact on implants than they have on teeth, because teeth have a gradient, a PDL. So you've asked a really tough question. I'm not answering it completely. What I'm trying to say is that it's a great question, kind of a complex answer. I think the risk assessment is necessary because if the patient has a high degree of risk, a lot of risk factors, and their score is pretty high, you better be pretty careful. Maybe you wouldn't build in canine disclusion on that side. If the patient has very few risks and their score is less than 6, and you, for aesthetic reasons, want symmetry between 6 and 11, then maybe that 11 implant supported crown could be as long as 6 and could be symmetric. So great question, good discussion point, convoluted answer.
All right. Thank you so much. If you have any questions out there, I know you would have they would have put it. Let me see. I think there's a question here. Okay, it was just a comment. Anyway, thank you so much, Dr. Curtis. I know if we have any more questions, email to us. I would forward them to you. It's been really. Thank you so much for.
Thank you for what you're doing, and hi to everybody around the world.
All right.
Great you're listening in. Bye-bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator